course on Canada for the one that is less familiar. And you get clearly here the 10 provinces down. And in this project, we study one in Eastern Province, Nova Scotia, then Quebec, Ontario, Manitoba, Saskatchewan, Alberta, and British Columbia. So it covers most of the Canadian population. And we use it as a kind of natural experiment where each provinces may be considered as a kind of natural laboratory for reform. Research methodology, I won't spend much time here, but we deal with 7 provinces. We selected them based on 2 criteria. Do they tend through time to engage its radical or very tumultuous reform versus take a more incremental approach? Do they tend to see reform as a whole system, whole health system endeavor versus focusing on some very sectoral policy like primary care? We perform sort of historical comprehensive case study of each province. The kind of narrative for each province is about 100 pages, and we perform a 54 interview with key policy leaders. So empirical finding, and for this analysis, we decide not to take as a unit of analysis each province. We sort of pull data using the empirical material of each province to get a sense of the manifestation of policy capacity in that reform. So looking at the first capacity as defined in the framework that we were invited to take into account for this work, analytical capacity, what we observe in terms of the mobilization of analytical capacity can be compared to what I guess you see in other jurisdictions, including England through time. In the early period of reform, it was a kind of open tent approach to policy making, bringing a lot of pluralism through public commission, interacting with a lot of stakeholders. And I will come back to this under political capacity, but the idea here is that it bringing on board a variety of evidence, of sources of evidence and viewpoints to a very open policy process. And then the later waves of reform seems to focus much more on targeted and confined approach to policy making, where you rely on more designated group like leader from the private sector that can be commissioned to write a report on the health system, some consulting firms, and we have an example just recently with Alberta where I think it's KPMG that produced a report to assess the performance of the system and so on. And then in terms of organization and analytical capacity, it's more a matter of central government try to create more tangible bridges between the operation, the delivery side of the system and policy and politics. And this is done through mandated management tools that healthcare organizations have to use, performance indicators and targets, and mandated reporting mechanisms. So something that is probably in the spirit of new public management, even if it's discussed less explicitly in the Canadian scene. Then individual capacity is observable through mobilizing policy and clinical leaders in these, for example, in these public commission, and also relying on some international profile, like, for example, some province bring on board Don Berwick from the US Institute of Health Improvement. So overall, in terms of analytical capacity, what we conclude is in the past 30 years, we see a real trend over time from focusing on capacity to generate a broad policy agenda, expanding the scope of analytical capacity in the hope of generating new policy idea, then moving uh, to reform that tend to put analytical capacity much more at the service of accountability and performance assessments, and a growing concern to bring data and intelligence around understanding patient experience, which may be seen as a positive spin of later wave of reform. Then moving to political capacity at system level, and in the paper we bring back as a kind of emblematic of this dynamic the question of the role of commission and broad policy forum. It not just relate to analytical capacity, it is really a kind of fertile ground to test the feasibility and acceptability of policy option. And in some province, this material is used really to sort of anticipate how a system, and it may be the system of profession, the healthcare organization, civil society, how the system will react and will see as more or less acceptable some policy option for reform. Then in later stage of reform, because you confine the policy process around probably more sectoral interests or limited group, you use political siblings, people that are well related to the government to work policy option in small group. And probably in that case, it's really a lot validating with an external group some preconceived approach to reform. So it's not a complete theory argument, but there's still a stronger political, I would say, flavor to this kind of work, and mostly right wing, as you can suspect. And then an important part of policy capacity in our analysis is the ability of government to strike formal agreement, for example, in our context, labor contract or with the medical profession that somewhat stabilize the relation between group or the relation between the government and unions in general. And it's a machine that helps generating trust and sort of installing minimal capacity to collaborate. Then you have a political capacity at the organizational level, and it's really here that government, and it will come back on operational capacity, so I will be short on this. It's the government that create all sort, and I'm saying it positively, of arm length agency, and you have this in England too, modernization agency, all sort of improvement agency, or evidence synthesis organization to support the delivery of the system. And what we observe is that professional organization, health worker relate quite positively to these agencies, and it sort of increased policy capacity to drive improvement in the system by creating this new space of collaboration, including these organizations provide support and resources. Then you have the individual dimension of political capacity. It seems to be influenced by the long-term tenure of prime minister. The profile of health ministers also influence the shape and content of reform. More they have a broad policy experience, less they seems to focus on a very narrow definition of healthcare and of health system as a social institution. And also a recent, I will say, involvement of operational leaders that came from the delivery side of the system and step in politics or in policy leadership role. So overall policy capacity is observable at various levels of analysis, and it seems to exert a powerful impact on the content and trajectory of reform. It has an element of realism, so political capacity reveals a lot of the politics with an S of health reform, and also the difficulty for government, and I will come back to this in conclusion, in riding very highly contested policy or political terrain in health reform. So operational capacity, we had difficulty in making a difference around operational capacity between system and organization and organizational capacity. These two categories seems to go together. One is the reflection of the other. What we observe in Canada is partly growing focus on the importance of operational capacity and the implementation dimension that was underlined in the previous presentation. There is partly as a result of some disillusion with structural change or legal change to drive reform. At this level, and I'm looking here more at the delivery side of the system, there is a growing but minimal role of consultant. Like some provinces really rely on consultant to generate operational capacity in the system with contract with government, but it's still a decision in most cases of individual care organization. Change in governance that we observe in 5 and 7 provinces seems to unpack a lot on the proximity between central government and the delivery side of the system. Saying differently, we observe a strong trend toward increased centralization, and this impact on the sometimes positively, sometimes negatively. I think the jury's still out on the connection between policy making and the operational dynamic of the system. Issues around, in terms of operational capacity, around data and human resources are pervasive across system, across reform, and we saw this in a very acute way in Quebec, for example, during the COVID-19 pandemics. The question of finding incentive to better attach medical doctor to broad system goal, because as you probably know, in Canada, they work a lot as individual entrepreneur, and how to better attach with incentive. It may be financial incentive is also a pervasive policy issue. We observe in terms of operational capacity, innovation and organizational design, like strategic clinical networks in Alberta, and a growing emphasis from government in supporting leadership development programs for improvement in that system. So operational capacity is more visible than before. That may be a take-home message. Impact on health system strengthening, mostly impact in 3 areas. I use that WHO term here, leadership, governance, but more on the side of governance. And partly capacity reflect growing emphasis on leadership development. Impact on delivery side of the system, as we underline, like looking at growing attention to capacity, looking at new organizational form and so on, and a growing attention to availability and supply of information and data. Much less ability to influence the true capacity development, to influence the way we finance provider, organization, professional, and it remains a major issue, including for long-term care. And it has been very, very challenging despite increased development in policy capacity to reallocate resources to growing priority to growing priorities such as mental health and home care and long-term care. So you get a sense that you're more equipped than before, but not enough, if I go back to introductory slide, not enough to challenge structural inertia and overall the kind of political economy that drive the Canadian health system. So conclusion, policy capacity is an evolving phenomena with something like fuzzy boundaries. It's very difficult sometimes to distinct system and organizational level capacity in the reforms we study. We observe a lot of interaction between analytical and political capacity, and both seems to mix nicely in some contexts, and it's something that we want to look further down the road in more detail. In the context of our political regime, you have a kind of ad hoc division of labor between federal and provincial government around the supply of policy capacity, federal focusing more on policy instrument with the aim to support province in their journey to improve the system, and provincial government really try to develop hands-on capacity to run and improve their system in a more direct way. Policy capacity is also a result of health reform, so it's not only impact on health system strengthening potentially, but it's also a result of many health reform in Canada that decide through reform to invest in development and deployment of some new capacity. And then you get the classic here, alignment across governance level is still a key capacity difficult to achieve. So to conclude, we have many more capacities today to think about and implement reform in Canada, but still see enduring system vulnerability and deficiency. In the Canadian experience, and probably I would say elsewhere, and this is an overgeneralization, capacity to maintain a high degree of political imagination and openness, and to muster the determination to push ahead with contested but progressive reform is part of the ideal toolkit of policymakers. So thank you. I stop there and thanks. And maybe Suzanne or Joanne wants to add something or later on.
Thanks very much, Anne-Louise, for taking time. And let's go for our discussants. David, can you please comment?
Okay, I was going to suggest that Rafael might want to go first because I've done a lot of
David, we are having problems to hear you. Can you maybe speak?
Can you hear me? Can you hear me?
But
yeah.
Then it goes, yeah.
Yeah, I'm sorry about that. I thought Rafael might want to go first because he's done less talking than me so far. I can come after him.
Okay, Rafael, can you go, please?
I'm happy to go, yeah. Thank you then. I think the paper adds a lot of value because I think what we've seen with COVID has exposed a rather weak capacity rather than a strong capacity in many of our health systems, especially at the policy level. I think there's been not obviously just exposed the lack of analytical capacity that something big was coming, but also the reaction, the improvised reaction. So I think that calls to complexity, and I'm making that most people, or at least policymakers and people that we would like to read these papers. Well, I think we have to, as as I think was mentioned before by Stephen Peckham, I think it is useful to make them as much as possible, even if they were written before, like ours, COVID related, because I think people are going to tend not to read or not to be influenced by things which are not related to that in the next year or year and a half. So I think it is useful to make those links. Obviously, there's tension between the vulnerabilities that were there and that are mentioned in the paper and what you can do about them. The ones that were there pre-COVID haven't disappeared. They're still all there. We've just added on a new layer of complexity, and to make the link is in some extent is going to be probably more difficult. But I think it's important to try so that we make it relevant to today, and not just relevant theoretically because we're interested in the policy sphere implementation. So the paper adds a lot of value in many of the issues that we're discussing. I think it's important, at least what I'm hearing in 3 countries, is that reform is going to be digital health. And I think we have to be a bit worried about that. There's a direct correlation in just about all the conversations that policymakers are going to think that they've done a reform because they've introduced very ambitious investments in digital health. Obviously, digital health is going to be one of the solutions, but it cannot be seen deemed. And that's where the paper comes in nicely, because the paper is saying, look, you better conceive capacity in a much broader frame. And the broader frame obviously is the framework you're using, which I think is useful. Macro, organization, individual. I think that's a useful way. But that of course to policymakers needs explanations. I don't want to downplay the capacity of our policymakers and many of our politicians, but a lot of our stuff, our paper and your paper, and I suppose other papers, are not written in a way for them to get it. So I think we're going to need some translation here as we move forward. I think both frameworks are very useful, the system, organization, and individual, to tell policymaker, look, make sure you, or the ones we're using, which is 5 Pettigrew areas, we're basically saying, both in your paper and our paper, we're basically saying, if you want to give a chance to the reforms that you're going to be launching, make sure you reason across these areas of capacity. Otherwise, you're not going to pull it off. And that's I think what both papers are trying to signify. That takes me to another comment in relation to, okay, how can we extract from the papers and from your papers, Jean-Louis and colleagues, how can we extract from them what is getting in the way of implementation? So not only make sure you address system organization and system and individual issues, but what is really getting in the way, so that they understand that a lot of the stuff that is getting in the way is the way they are thinking about the implementation. So I think it is useful to try to extract from the paper, I'm not sure if a list or at least some very clear points of saying, look, you can implement successfully if you think this way, but you have to make sure some of the things that are getting in the way and start getting out of the way. So, for example, you introduced the central and provincial discussion, which I think is very important, because there are more and more countries trying to, let's say, federalize, or trying to learn from those of you who have been in federal countries for a long time. Even France this summer, Macron is saying, I'm going to decentralize France, which is, if France decentralizes, that means everybody's going to decentralize. So basically, I think it's important for us to say, okay, how can we extract from the paper 2 or 3 things that have to be identified, that we've learned are barriers between the central and the provincial layers, and that we can probably start fixing in such and such a way. The other final point is simplification. For me, both ours and yours just need simplification if we're assuming we want to address policymakers. If we're addressing the academic field and we're addressing others, then maybe that's not so important. But if we're trying to tackle and be, which is what David and I were trying to do with this WHO project. We were even trying to get WHO out of this, just telling countries what to do, and start helping them with some of the hows. I think we're going to be more relevant with this whole battery of papers if we simplify, or at least we extract, as I was mentioning before, what comes out of the analysis. So I would leave it at that. Maybe David, you can amplify.
Okay, thanks. Okay, so David, please.
Okay, I'll be very brief. A very good paper, lots of rich insights into provinces in Canada, but also resonances with other countries, and certainly the work that Rafael and I covered in our paper. I like the idea of political gridlock and structural inertia being all too familiar factors. I think highlighting them was good. Context is really important. As Rafael said, we've got the distinction between centralized systems and federal systems, and policy capacity will be affected by those structural systemic factors. So context is really important, as we've been saying. I like the point about policy frames and the dichotomy between producing healthcare and producing health. They are distinctive, they're coming together, but they are distinctive, requiring different skills and ways of working. So I thought pulling that out was interesting. And there's a risk that healthcare will predominate over health, as has tended to happen in many health systems. I think the powerful impact of political capacity that Jean-Louis emphasized is really important. I think that resonates with our project a lot. And finally, I like the distinction between high-level politics detached from operational issues, what we called operational disconnect, that policy implementation gap, because of a disconnect between what people are doing at the center in terms of forming policy and what's happening locally or regionally in terms of implementation. So lots of echoes in the paper that resonated with our work, and I really enjoyed reading it. Thank you.
Really brief. So I think we can now open the floor. I invite everyone to come in. David, do you want to react quickly, or let's open for more questions and then you react all together? Okay. So Fabiana, you had a question. Do you want to speak? No, she's not speaking. Let me. I have a question. When David began, was very.
Jean-Louis.
Fabiana, do you want to speak now?
No, just you keep on saying David. Maybe it was Jean-Louis. Not sure what you meant. The presentation was from Jean-Louis.
I'm coming with a question, and the floor is open.
Okay.
We may have some more questions. Okay. So David was a lot of emphasis on the idea that's not about the what, no, but about the how. And for me, reading both articles, I was thinking, can we really think about the how without the what? Because you have very different ways of looking at the reform process. It seems to me that in the first paper, okay, the content of the Sweden and the British reforms are okay, and we are really problematizing how difficult it is to have all the needed capacities in place to implement it. You know? While in the second article, I feel that the authors were much more critical to the content of the ongoing reforms. You know? And looking at how Jean-Louis and colleagues worked, it seems to me that the what makes a lot of difference in the how. You know? So I appreciate the distinction they made about different capabilities affecting differently changes. They suggest that organizational capacities have been effective in changing governance and service delivery, but not priorities, financing, or incentives. So while in Canada in recent years, we had a lot of analytical capacities, organizational capacities, there was a decrease in political capacity. Is this right, Jean-Louis? Yeah.
Well,
okay.
I would say not necessarily a decrease, but a change in nature of political capacity. But I agree with you that a change that reduces the chance to have bold and more audacious policy.
Yeah. I have to say I was not entirely convinced by the narrative. It seemed to me that the authors don't support very much the kind of reform that evolved in Canada in recent years. And you suggest that this is related to a lack of political capacity. You know? I'm not completely convinced, but I am convinced that's a good idea to explore more systematically how different aspects of the reforms, if you are trying to do something in governance or in service delivery or priorities or financing, this requires different combinations of analytical, political, and organizational capacities. So that you really, the what is important to think about what capabilities you need to mobilize. And so maybe this is a suggestion that in the next versions or in the other articles, we could work more these distinctions, not only recognizing which capacities count, but also which capacities count for what kind of changes. So this would be my reading of how we can move further.
Thank you.
Mm-hmm. So, other questions? Fabiana, go ahead.
Yes. So now we come to the end of this first day in our workshop. We'll have another one on the 13th of August. Yes, 13th. And then we'll start very early with a short session from New Zealand. In Tebas I will be speaking, and then we'll give a break for the Brazilian and Canadians to rest a bit because it's very early in our country, and we'll come back again 10 a.m. in Brazil. We'll have about 4 papers, on India, on China, on Brazil, and the broad policy framework that will be put together in our initial paper in the issue. And you are still hoping to receive a proposal for people working on African countries, because the 2 others, they were considering to become part of this publication, they won't be able to do it. So I send a call with the Shapes Health System Global, and I hope to receive good proposals from there, focusing on African countries. I just like to remind you that it's a public policy journal. Yeah, I'll repeat a little bit what I said at the beginning. So please give details about the connection between the public policy framework, but not only the other also concepts and framework from public policy that you have used in your framework or in your analytical methodological section. Just keep mentioning them and the combination of them during the analysis and in the conclusion. If the policy capacity framework is not strong enough, or just the concept, the dimensions, the elements you have taken from the framework, they are not very strong enough in your analysis, mention, look, it turned out to be not a very strong element. You can be critical to the framework from your analysis if it's not, or you can say, no, it was good to use it. Because the theme issue is on the policy capacity framework and system strengthening. So at the end, you need to bring those elements. I like very much both papers, and at David's paper, I felt that at the end, he could have brought a little bit more from public policy. And also when he points out the elements in his transformational framework, maybe in those elements, you could think a bit of public policy concepts or issues that are there. Yeah, the leadership deals with strengthening, so it's a way that you bring in strengthening. The relationship between the frontliners has to do with the strengthening of the workforce, so that's a way of bringing the strengthening literature. And then you say, yes, we're talking about transformational, and that's a way of bringing strengthening policy capacity like this. Yeah, the paper is very good. The comments were excellent. Jean-Louis proposed a more political alternative, and I find it quite very good as well. The way you relate the concepts and you think in terms of the types of policy capacity and the way it might be influenced. Vera have explained it and reviewed it very nicely. So I'm satisfied with all the papers. And I wonder if David and Rafael are thinking of put together tables of boxes or even a design, a figure to explain their framework as an annex and alternative when they're going to do their submission. Only if you have think about that. So don't be afraid to be critical to the policy capacity framework. Yeah, it's fine. And just keep on your mind always that it's a public policy paper. It's not a health system or health policy journal. I mean the journal. It's a public policy journal. So public policy concepts and frameworks, they need to be there. We have selected the policy capacity framework, but you are welcome to use together with the policy capacity other concept as well. I'd like to invite Stephen Peckham for final comments, and after Stephen, you please give the opportunity to Gerald to talk as well, and then we can close today's section and we'll come back on the 13th of August. Stephen, are you there? Would you like to talk a bit at that?
Maybe Jean-Louis, 30 seconds just to say thank you to Rafael, David, and Vera for the comments.
Okay.
Because I did not have opportunity to say it. Thank you.
Yeah. And anything you'd like to add, the other authors and even the discussions, just do it via email. You can do it in the group email we have there, or you do it individually to the author. So that keep the discussions going on. Stephen?
Thanks, Fabiana. Yeah, I mean, generally, I enjoyed your paper, just to say, but I think your comments, Rafael, were pertinent, and it does raise, you know, kind of doing, when we obviously first thought about doing this series, it was not in the current context of what might affect health systems and policy implementation. So I think just one comment, because it did come up in both papers, and you touched on it, Rafael, this, you know, the focus on implementation and not just thinking about kind of policy impact on transformation, but that whole issue of having to follow policy really through to fruition. That it is no good just looking at sometimes the first part of that, and in thinking about implementation, we are beginning to push boundaries of how we bring different kinds of kind of critical thinking to the notion of systems and systems transformation and the policy kind of nexus in relation to that. So I think those two points are probably worth thinking about. I think the great thing is, I mean, we've been looking mainly at fairly developed systems today, but I think the interesting thing will be as we set these sorts of things alongside issues in lower and middle income countries. I must admit, when I was working more at London School of Hygiene and Tropical Medicine, doing health policy, I always felt that the kind of issues and the questions were always the same, and the context, and therefore David and Rafael's paper around thinking about that as a framework becomes quite relevant, because it's often that bit which is different, not the problems. It's often the context that they're applied to. So thinking about how kind of systems transformation and policy systems in relation to that, I think is beneficial in drawing on these other kinds of frameworks. So I thought that's quite interesting and something that may be picked up in other papers as well. But otherwise, to thank you, and sorry that I missed your presentation, David and Rafael, but I did read the paper, and thank you for the comments, Jerry and Rafael and David, on those points and the discussion, and thank you for Vera for chairing that second session, and Nick the first one. So I look forward to further discussions in August. Thanks, Fabiana.
Thank you. Jerry,
Okay.
would you like
Well,
to add something?
Sure. I mean, first, two very good papers. I was trying to think of what to say, but in a way, it's interesting that at the end of the one on Canada, you brought up the same thing. I mean, can policy capacity be basically conservative and a block to transformational change? And in a way, the Canadian one also brings up the question of imaginative leadership. So it's not just any old capacity that seems to be people are referring to, but a particular kind of capacity that can envisage transformational change. And I guess the question is why? And it'll come back to what Rafael said, well, and what Alex said, actually. COVID and the very likely prolonged recession that's going to follow it are starting to ask questions about the stability of the systems, or of the need for quite substantial change, as is the development of new technology. And so we may want to look a little bit more as we go on of what we really mean by policy. What kind of capacity are we talking about? And if once we bring that question, which is what Vera said, once we're talking about transformational change, it's impossible to separate the where are we heading from the how are we heading, and from the learning from making the mistakes and learning about a complex system as one moves forward. So it could well be those boundaries get blurred as well. But I thought it interests me that starting in what we would have thought as the most stable health systems with the most well-established institutions, including for development and commenting on policy, we're finding quite a lot of concern about the capacity for those systems to adapt to really a rapidly changing environment. I think it's going to be less of a surprise what we find in Brazil or in China, where the existence of periodic shocks and the absolute knowledge that things are changing rapidly is right in the middle of the policy process. So I think we're coming towards a very interesting addition, and I do think people are going to be thinking differently about the policy process because of the education of the COVID crisis. So I think we may have a readership, but it will take quite a lot of creativity to pull this together. That's where I'll leave it.
Thank you, Jerry. Well, thank you all very much. And anyone has any final comments or question? Alex, would you like to make any further comment, question?
No, thanks. I thought that was really, really interesting and look forward to subsequent conversations. Thanks a lot.
Thank you. Well, thank you all for sharing your thoughts, then your comments and the discussion. And we'll see you all again on the 13th of August. Thank you, David. Thank you, Rafael.
Okay.
Thank you, Jean-Louis. Thank you, Vera. Thank you,
Bye
Nick.
now. Bye.
Nice work. Nice work. Very hard working people.
Thanks all.
It's a shame the live stream didn't work well. I think that Facebook in Brazil is very busy now. It's a holiday in Brazil. Lots of people are doing workshop, but the test I did yesterday, it was fine. It worked brilliant. Anyway, next time maybe we'll get it. But the video has been recorded, and I also did some small videos of each one, and I'll be upload them later. Thank you all. Bye-bye.
Good. Bye-bye.
Bye-bye. Bye-bye. Bye-bye. Thank you.
Bye-bye.
Thank you, Stephen.